Hi everyone, and welcome to our module on diabetes. Diabetes is a chronic disorder of elevated blood glucose levels, and it can be caused by either insufficient insulin production by the pancreas or insufficient response to insulin by peripheral tissues. This is referred to as insulin resistance, and sometimes it's caused by both of these reasons. Many people who have diabetes are unaware they have the condition. Especially in the early stages, it's often asymptomatic. It's sometimes referred to as one of the silent killers along with hypertension. There are often no symptoms of diabetes until a serious complication develops, and this is the basis for screening patients for diabetes. If patients do develop symptoms, it's often from hyperglycemia, and the symptoms that you can see with significant hyperglycemia include polyuria and polydipsia. So the polyuria means frequent urination, and this is because glucose in the urine acts as an osmotic agent and causes an osmotic diuresis. The polydipsia is increased thirst, and that's thirst to replace the lost fluids in the urine. A brief word on terminology. Diabetes mellitus is what we're talking about in this module now. The word mellitus means sweet. Diabetes mellitus was named because the urine of patients who had diabetes mellitus was sweet from the presence of glucose. This is a very common disorder. Diabetes insipidus, on the other hand, has urine that lacks flavor. That's why it's called insipidus, because the word insipid means lacking flavor. And diabetes insipidus is a very rare disorder related to low activity of antidiuretic hormone. The reason both of these disorders were initially named diabetes is because they can both cause polyuria and polydipsia. However, the underlying mechanisms are completely different. To make the diagnosis of diabetes mellitus, you can measure the plasma glucose level. If the patient has symptoms of polyuria and polydipsia, any glucose level greater than 200 makes the diagnosis of diabetes. On the other hand, patients who are asymptomatic and who are being screened for diabetes need to have measurement of a fasting blood glucose level, which means no food for 8 hours. The reason you have to be fasting is because it's common for your blood sugar level to elevate after a meal when you consume sugar. However, when you are fasting, the blood sugar level should be low. If the fasting blood sugar level is less than 100, that's considered normal. If it's 100 to 125, that's considered prediabetes. And a fasting blood glucose level greater than 126 is considered a diagnosis of diabetes. Another test that is often performed in order to diagnose or monitor diabetes is measurement of the plasma level of hemoglobin A1C. A small fraction of the hemoglobin in plasma is glycated. This means glucose combines with amino acids in the alpha or beta chains, and the subfraction called hemoglobin A1C is useful for diagnosing and monitoring diabetes. Hemoglobin A1C is created by non-enzymatic glycation of the beta chains. Non-enzymatic means this reaction does not require an enzyme. Glycation means that glucose molecules are added to the beta chains. This occurs at the amino terminal valine. If you look at this picture on the screen, this is a molecule of hemoglobin, and as you know, hemoglobin is made up of amino acids. Some of the amino acids found in the beta chains are valines, and valines, as you know, have an NH2 group. Glucose will be added to these NH2 groups without an enzyme, hence it is called non-enzymatic glycation of the amino terminal of the valines. And when this occurs, you create molecules of hemoglobin A1C, and you can measure the amount of hemoglobin that is hemoglobin A1C and use that to monitor or diagnose diabetes. So the higher the plasma glucose, the more hemoglobin A1C that will be created. That should make sense to you. When there's more glucose around, it's easy for it to combine with those terminal valines. However, measuring the hemoglobin A1C is more helpful sometimes than measuring just the plasma glucose, because plasma glucose is just one point in time. However, the hemoglobin A1C value reflects the average glucose over the past 3 months. The reason for this is because red blood cells survive about 3 months. So, for example, imagine a patient with a very high blood glucose level. They will create lots and lots of hemoglobin A1C. However, if they then control their blood sugar over the next 3 months, all that A1C will wash out of their body as the red blood cells die, and the hemoglobin A1C will begin to fall. Thus, what you're seeing when you measure the A1C is a measurement of what's been happening to the blood glucose over the past 3 months. A normal value for A1C is less than 5.7%. Prediabetes is 5.7 to 6.4, and anything greater than or equal to 6.5% suggests diabetes. This is sometimes used for diagnosis, although it's much more important for monitoring therapy. You will measure the A1C in patients who are diabetic, and if the value comes back high, this means they have poor control of their blood sugar and you need to adjust their medications. A final way to make the diagnosis of diabetes is to perform what's called a glucose tolerance test. This is where the patient is asked to consume an oral glucose load. It's usually a very sugary drink, and then the plasma glucose level is measured 1 to 3 hours later, and if the value of glucose in the serum is high, this indicates diabetes. And this is the way that diabetes is often diagnosed in pregnancy. You can screen for gestational diabetes, and the reason for this is because some insulin resistance is normal in pregnancy, so measuring just a fasting blood sugar level is not always helpful. You need to study the response to the glucose load in order to make the diagnosis. Now let's begin our discussion of the pathophysiology of diabetes. As you may know, there are two types of diabetes, type 1 and type 2. Type 2 is by far the much more common type, but we'll talk about type 1 first. So type 1 diabetes is an autoimmune disorder. It is an example of a type 4 hypersensitivity reaction, which means it is a T-cell mediated disorder. In type 1 diabetes, there is T-cell mediated destruction of beta cells. There is inflammation of the pancreatic islets. You can see lymphocytes in the islets on biopsy. This is sometimes referred to as insulitis. There is also a decreased number of beta cells seen on biopsy, and importantly, from a pathophysiology standpoint, the T-cell mediated inflammation leads to a loss of insulin. Like many autoimmune disorders, this is associated with certain human leukocyte antigens. Type 1 diabetes is associated with HLA-DR3 and DR4. There's also sometimes autoantibodies that are found. They're not part of the pathophysiology of the disease, but they can be detected in the serum. You can see islet cell antibodies and sometimes insulin antibodies. Type 1 diabetes is mostly a childhood disorder. It has a bimodal distribution. There is a peak onset at 4 to 6 years of age and a second peak at 10 to 14 years of age. And because children with type 1 diabetes can completely lose insulin production from the pancreas, they often get very high blood sugar levels and present with symptomatic hyperglycemia. So they present with classic symptoms of diabetes like polyuria, polydipsia, and glucose in the urine. And the treatment is to replace insulin. So children with this disorder require lifelong insulin. And I talk about treatment of type 1 diabetes in other modules. Diabetic ketoacidosis, or DKA, is a life-threatening complication of diabetes, and it is much more common in type 1. We'll talk about why in a minute. It is a common initial presentation of type 1. The blood sugar can get so high that the patient develops diabetic ketoacidosis and presents with symptoms of DKA. It's often precipitated by infection or trauma. We'll talk about why this is the case, and it can also occur when a type 1 diabetic skips their insulin therapy. So remember that type 1 diabetes is a disorder of children, and when children get to become teenagers, they often become rebellious, and sometimes they don't want to take their insulin and they skip therapy, and they can get very sick, and one of the complications they can develop is DKA. The development of DKA requires low insulin. This is why DKA is much more common in type 1 diabetics who lack insulin than it is in type 2 diabetics who typically still have some pancreatic insulin production. The low insulin leads to high glucagon, and that is the first step in development of diabetic ketoacidosis. It also often occurs in the setting of trauma or infection, as I said before, and that's because in those two settings you also have high epinephrine, which combines with the low glucose and high glucagon to create the perfect setup for DKA. The first thing that develops in DKA is the glucose level gets very high. In addition, there is an increased breakdown of fatty acids via lipolysis. All of this leads to high development of ketone bodies, and some of the ketone bodies are acids, and therefore you can develop an acidosis. One of the ketone bodies that is produced is acetone, and acetone is exhaled in the breath, and therefore patients with DKA classically have a fruity smell on their breath. The acidosis also raises the plasma potassium level, and therefore hyperkalemia is very common in diabetic ketoacidosis. Other features of diabetic ketoacidosis include polyuria from glucose spilling into the urine, and this can lead to dehydration and potentially low blood pressure. In addition, there will be ketones and glucose detected in the urine. The polyuria can deplete the body of phosphate, and you can potentially develop low phosphate levels. And then finally, classically, patients with diabetic ketoacidosis present with abdominal pain, nausea, and vomiting. The reason for this is believed to be because acidosis slows GI motility, and the high epinephrine levels also slow GI motility. So this slide summarizes the clinical presentation of DKA shown on that concept map. The patient will present with abdominal pain, nausea, and vomiting. There is dehydration, hyperglycemia, and hyperkalemia. There can be elevated plasma and urine ketones as well as glucose in the urine. There is an anion gap metabolic acidosis from the high levels of ketones. This can lead to what's known as Kussmaul breathing. This is deep labored breathing. The body is hyperventilating in an attempt to blow off carbon dioxide and raise the pH in response to the acidosis. And then finally, there is classically a fruity smell on the breath from acetone. In the biochemistry module on ketone bodies, I talk more about the biochemistry of DKA, but I'll just review a few of the highlights for you here. In the setting of low insulin and high epinephrine, there is high utilization of fatty acids. Fatty acids can be converted to acetyl-CoA. Normally, acetyl-CoA can enter the TCA cycle by combining with oxaloacetate to form citrate. However, in the setting of low insulin and high epinephrine, all the oxaloacetate is being driven towards glucose. This means there is not much oxaloacetate around to combine with acetyl-CoA, and therefore ketone bodies are produced. In addition, the metabolism of fatty acids leads to the production of lots of NADH. NADH favors the conversion of oxaloacetate into malate, so this is another reason that oxaloacetate is depleted and the TCA cycle is stalled. And for all of these reasons, all the acetyl-CoA coming from fatty acids is driven towards the production of ketone bodies in DKA. As I mentioned in the concept map, there is a risk of hypophosphatemia in DKA. The acidosis can shift phosphate out of cells and into the extracellular fluid. The phosphate can then be lost in the urine. There is significant phosphaturia caused by the osmotic diuresis, and if this is severe, the phosphate level can get very low. If it gets really low, you can lose your ability to produce enough ATP. This can lead to muscle weakness, which can present as respiratory failure. A classic board question is a patient with DKA who has respiratory failure. You should always check the phosphorus level. You can also potentially develop heart failure from poor contractility without enough ATP. Arrhythmias can also occur and are sometimes a cause of death in DKA. This is from the hyperkalemia. And finally, cerebral edema can rarely occur. The mechanism of this is poorly understood, but this is a common cause of death in children who have severe DKA. Another rare complication of DKA that you should know about for your boards is the fungal infection called mucormycosis. Mucormycosis is caused by a species of fungi called Rhizopus or mucor. Classically, this infection starts in the sinuses and spreads to adjacent structures. The reason this is common in DKA is because these fungi thrive in the high glucose ketoacidosis conditions. So the classic way for this to complicate DKA is for a patient to have DKA and then in the recovery phase develop a new fever, headache, and eye pain. That patient may have the infection mucormycosis. The treatment of DKA is to administer insulin. This will lower blood glucose levels. It will also shift potassium into cells to treat the hyperkalemia. In addition, you need to administer IV fluids because these patients are dehydrated from the polyuria, and this will treat the dehydration. When you are treating DKA, you need to carefully monitor the potassium level. It's very high yield to know about this for your boards. Even though the patient has hyperkalemia, the total body potassium is low because lots of potassium has been lost in the urine. When you administer insulin therapy, you will begin to shift potassium into cells, and this can lead to hypokalemia. Usually after a few hours of therapy with insulin, you need to add potassium to the IV fluid so that the patient does not develop symptomatic hypokalemia. In addition, you need to carefully monitor the glucose. As you administer insulin, the glucose level will begin to fall, but you can't stop the insulin when the glucose gets low. You need to continue it until the acidosis goes away. Remember, the acidosis is responsible for many of the symptoms of DKA. This means that after a few hours of insulin therapy, you often have to add glucose to the IV fluids while the insulin infusion continues, and then keep the insulin going until the acidosis has completely resolved. Moving on, now let's talk about type 2 diabetes. So type 1 diabetes was caused by a loss of insulin production from the pancreas. Type 2 diabetes, in contrast, is caused by insulin resistance. Muscle tissue, adipose tissue, and the liver become resistant to the insulin hormone. When there's a reduced response to insulin, hyperglycemia develops. The pancreas responds to the hyperglycemia by increasing its insulin production. So initially in type 2 diabetes, you can have high insulin production despite hyperglycemia. Eventually, the pancreas can start to fail and the insulin level can become low. But the important point here in terms of physiology is that the insulin level can be high or low depending on the stage of the disease. This is the most common form of diabetes. It's much more common than type 1, and this is common in adults. The prevalence is actually rising. It's also becoming more common among children. A major risk factor for type 2 diabetes is obesity, and this is believed to be one of the reasons that the incidence of type 2 diabetes is rising, because the incidence of obesity is also rising. And different types of obesity carry different risks for diabetes. Central or abdominal obesity carries the greatest risk in terms of diabetes. In addition, intra-abdominal or visceral fat around your organs inside your abdomen carries greater risk than fat that is under your skin, so-called subcutaneous fat. One of the reasons this is believed to be the case is because visceral fat breakdown is less inhibited by insulin. Therefore, when you have lots of visceral fat, you will have more lipolysis because lipolysis is not being inhibited by insulin, and this will lead to more free fatty acids. And I've bolded the word free fatty acids because there are more free fatty acids around in patients with diabetes and intra-abdominal fat, and this is believed to contribute to the diabetes. It's thought that the fatty acids get used for fuel instead of glucose, and therefore there is decreased glucose transport into cells. Another thing you should know about risk of diabetes is that the apple shape is worse than the pear shape. People with an apple shape tend to look like this. Lots of their fat is in their abdomen in the middle. People with a pear shape tend to look like this. They carry lots of their fat in the subcutaneous tissue around their hips. So the apple shape is due to increased visceral adipose tissue. That is the worst kind of tissue in terms of diabetes risk. The pear shape has more subcutaneous tissue, which is less bad in terms of diabetes. And an important point to remember about all the items on this slide is that weight loss improves glucose levels, and that's one of the ways to treat diabetes is to encourage the patient to lose weight. Family history is also very important in terms of risk of type 2 diabetes. There is a strong genetic component, stronger than in type 1 diabetes. A patient who has any first-degree relative with type 2 diabetes mellitus has a 2 to 3 times increased risk of developing the condition. The precise mechanism for insulin resistance in type 2 diabetes is not known. However, you can imagine with this disorder being so common, there is a lot of basic science literature looking into why patients develop insulin resistance. And you should know that there are many data that suggest abnormalities of the insulin receptor. I talk about the insulin receptor in more detail in the module on the endocrine pancreas. What I want to mention here is that there are data that suggest that fatty acids may modify the insulin receptor by activating enzymes called serine threonine kinases. The bottom left side of the screen is the structure of the amino acid serine. At the right side of the screen is the amino acid threonine. And these amino acids are found in the beta chains on insulin receptors. And these serine threonine kinase enzymes may phosphorylate these amino acids. And when they become phosphorylated, the insulin receptor becomes inhibited in conducting tyrosine phosphorylation, which is an important step in activation of the insulin receptor. Other data suggest that increased levels of TNF-alpha may lead to insulin resistance. TNF-alpha can be synthesized by adipocytes, and there's evidence that this intermediate may activate the serine threonine kinases and therefore lead to problems with the insulin receptor as I just described. You should know the classic histologic finding on a biopsy of a patient with type 2 diabetes, and that is the presence of amyloid in the pancreatic islet cells. There is a protein called amylin that is normally produced by beta cells. Its precise physiologic function is not entirely worked out, but it is packaged and co-secreted along with insulin. And in the module on diabetes treatment, I talk about a drug called pramlintide, which is an amylin analog that is used for diabetes treatment. For our purposes here, though, what you should know is that the amylin can accumulate in the islets in patients with type 2 diabetes, and this gives the appearance of amyloid inside the pancreatic islets. HHS is the hyperglycemic hyperosmolar syndrome, and this is a life-threatening complication of diabetes that shares many features in common with DKA. However, like I told you before, DKA is much more common in type 1. HHS is much more common in type 2. We'll talk about why in a minute. In HHS, there is a very high glucose level which leads to diuresis. The glucose level can get so high it can be over 1,000. This is so elevated that it leads to a marked diuresis and the patient can become severely dehydrated. There are a couple of differences from DKA that you should know about. First of all, there are usually few or no ketone bodies present, and the reason for this is because in type 2 diabetics, there is some insulin still present. There are some beta cells that are still functioning. Therefore, usually there's enough insulin around to prevent the formation of a significant number of ketone bodies. For this reason, there is usually no acidosis, so all the symptoms of acidosis we talked about before in DKA do not occur. What does happen in HHS is that the glucose level gets so high that there is very high serum osmolarity, and this can lead to CNS dysfunction, which is much more characteristic of HHS than DKA. The symptoms of HHS are polyuria and polydipsia from the high blood glucose levels. This leads to dehydration, and then there are characteristic mental status changes like confusion and coma, and the treatment is similar to DKA with insulin and IV fluids. We've talked about many of the presenting signs and symptoms of diabetes like polyuria and polydipsia and DKA. Let me tell you about one other sign of diabetes, and that is a skin finding called acanthosis nigricans. These are hyperpigmented plaques that appear on the skin. They classically occur at intertriginous sites. These are places where the skin folds. Classic places for acanthosis nigricans to appear are in the back of the neck or in the axilla. If you look at the picture on the right side of the screen, this person has a dark plaque on their axilla. This is an example of acanthosis nigricans. The mechanism for this skin finding is poorly understood, but acanthosis nigricans is strongly associated with insulin resistance. You will see it in people who are obese and people who have diabetes. In addition, it is rarely associated with malignancy, and among the different malignancies associated with acanthosis nigricans, gastric cancer is the most common. For the remainder of this module, I'm going to talk about complications of diabetes. Whether you have type 1 or type 2 diabetes, the chronic hyperglycemia leads to a common set of complications that occur in both disorders. This includes heart disease, kidney disease, neuropathy, and blindness. We'll talk about all of these things. What you need to know for step 1, however, is that underlying many of these complications of diabetes are two key mechanisms. The first is non-enzymatic glycation. The second is sorbitol accumulation, and both of these probably play a role in many of the complications of diabetes. Non-enzymatic glycation is the same process we discussed earlier in this module regarding hemoglobin A1c. It's when glucose is added to amino groups on proteins without an enzyme being required, hence the name non-enzymatic. It's driven by high glucose levels, so chronically elevated glucose levels lead to more non-enzymatic glycation. The glycated proteins can become cross-linked, and this can lead to substances called advanced glycosylation end products, or AGEs, and these underlie the pathophysiology of many of the complications of diabetes. AGEs have been shown to play a role in the development of atherosclerosis among diabetics. This is sometimes referred to as an example of diabetic macroangiopathy because this disease process involves the large blood vessels. AGEs have been shown to trap LDL in large blood vessels, and this can lead to atherosclerosis. And diabetics have increased rates of all forms of atherosclerosis. They have increased rates of coronary artery disease like angina and myocardial infarction. There are more strokes and TIAs among diabetics. And finally, many diabetics have peripheral vascular disease. This is where there is narrowing of blood vessels, as is shown in this picture, in the arteries that supply blood to the extremities, especially the legs. This can lead to the development of claudication, which is pain in the legs with walking. There can be ulcers on the skin called arterial ulcers. There can be poor wound healing of wounds in the lower extremities, and if it progresses, peripheral vascular disease can potentially lead to gangrene and amputation of limbs. Advanced glycosylation end products have also been shown to play a role in diabetic kidney disease. This is sometimes referred to as an example of diabetic microangiopathy. The word micro is here because now we're talking about small vessels, not large vessels like coronary arteries. The AGEs can lead to damage to both the glomerulus and the efferent and afferent arterioles, and for many diabetics this leads to end-stage kidney disease. A very common reason for patients to be placed on dialysis is because of diabetic kidney disease. You can think of diabetes as damaging the kidney in three ways. Diabetes can affect the afferent arteriole, the efferent arteriole, or the basement membrane. When the afferent arteriole is damaged, this decreases the renal blood flow, and that can precipitate renal failure. When the efferent arteriole is damaged, this leads to hyperfiltration, which we'll talk about on the next slide. That can lead to albumin in the urine. It can also lead to renal failure. And then finally, when the basement membrane thickens, this is called glomerular sclerosis. This is an effect of diabetes, and this also contributes to renal failure and renal insufficiency. So let's talk about how diabetes affects the arterioles in the kidneys first. Diabetes leads to the development of hyaline arteriosclerosis. This is a picture of hyaline arteriosclerosis shown on the screen here. You can see that there is this pink stuff that has narrowed the lumen of this arteriole. That pink stuff is hyaline, and this is what happens in diabetic kidney disease. There is thickening of the arterioles. You can also see hyaline arteriosclerosis in hypertension. In diabetes, this may result from advanced glycosylation end products. They have been shown to cross-link collagen, and that's believed to be one of the mechanisms by which hyaline arteriosclerosis develops in the kidneys. This commonly occurs in the kidneys of diabetics and can involve the afferent and efferent arteriole, and different things happen depending on which arteriole is affected. If the afferent arteriole is narrowed by hyaline arteriosclerosis, that leads to ischemia. If the efferent arteriole is affected, that leads to hyperfiltration. To understand this, let's imagine we have a glomerulus here. This is the afferent arteriole, and this is the efferent arteriole. If you have narrowing of the afferent arteriole, that will decrease the blood supply to the nephron and cause ischemia, and that's the way that kidney damage can occur in diabetes. If the efferent arteriole is damaged, you will raise the pressure in the glomerulus. This will lead to hyperfiltration, and that's how you can get albumin in the urine. Both of these can contribute to damage to the kidneys and ultimately to end-stage renal disease. And a key point to note here is that efferent arteriosclerosis is rarely seen except in diabetes. That is a relatively unique feature of diabetes, something that is high yield for you to know for your boards. While we're on this topic, let me pause and mention proteinuria in diabetics. Diabetics are screened annually for evidence of albumin in the urine because it is an early indicator of diabetic kidney disease. And there is good clinical trial evidence that protein in the urine is an indication for an ACE inhibitor. ACE inhibitors have been shown to reduce the progression to end-stage renal disease among diabetics. One of the potential mechanisms for this effect is dilation of the efferent arteriole. I just told you that the efferent arteriole is commonly affected in diabetes, and ACE inhibitors preferentially dilate this portion of the kidney. This will reduce the hyperfiltration, and this may be why ACE inhibitors reduce the progression to end-stage kidney disease. Advanced glycosylation end products can also affect the basement membranes of the kidneys. They can lead to diffuse basement membrane thickening. This can be seen on electron microscopy of the glomeruli of patients with diabetes. This can lead to proliferation of the mesangium. The mesangium are the cells in the matrix that surround the glomerular capillaries. And if they begin to proliferate and the matrix increases in size, you will get sclerosis of the glomeruli, which is called glomerulosclerosis, and that's what can happen in diabetes. There are two forms of glomerular sclerosis that can be seen in diabetes. The first is the diffuse form. This occurs when there is deposition of proteins, especially collagen type 4, diffusely on the basement membranes of the glomerular capillary loops. The mesangial cells begin to proliferate, and this is what leads to diffuse glomerular sclerosis. You can also see this with aging and with hypertension. And if this process becomes severe, this can lead to the nephrotic syndrome, and it's uncommon, but sometimes diabetes leads to development of the nephrotic syndrome. What is more specific to diabetes is development of nodular glomerulosclerosis. This is where nodules form in the periphery of the glomerulus and the mesangium, and this rarely occurs outside of diabetes, so nodular glomerulosclerosis is much more specific to diabetes. And both of these processes can lead to fibrosing and scarring of the entire kidney, and this is how diabetic patients can end up on dialysis. This is a picture showing a Kimmel-Steele-Wilson nodule. This is the hallmark of the nodular sclerosis seen in the glomeruli in diabetes. This is pathognomonic of diabetic kidney disease, and this is a classic picture that you need to be able to recognize for your boards. So non-enzymatic glycation is one underlying mechanism of some diabetic complications. The other underlying mechanism of diabetic complications that you should know about is accumulation of sorbitol, and this occurs via a biochemical pathway called the polyol pathway. As you know, glucose can be metabolized via glycolysis, but there is an alternative pathway for glucose metabolism called the polyol pathway that occurs in some cells in the body. Glucose can be converted into sorbitol by an enzyme called aldose reductase. Sorbitol can then be converted into fructose via an enzyme called sorbitol dehydrogenase, and as you know, fructose is one type of carbohydrate that can enter the glycolytic pathway. The polyol pathway has little activity at physiologic glucose levels. However, chronic hyperglycemia activates this pathway more than usual, and this leads to an accumulation of sorbitol. As I showed you before, sorbitol can be metabolized into fructose, but this is a slow process or sometimes doesn't occur at all in some cell types. This leads to a buildup of sorbitol, and sorbitol is an osmotic agent. This will draw in fluid and lead to osmotic damage of cells, and this is likely involved in many diabetic complications, especially cataracts and development of diabetic neuropathy. Cataracts are more common among diabetics, and sorbitol accumulation is believed to play a role in the development of diabetic cataracts. Sorbitol can accumulate in the lens of the eye. This can lead to increased osmolarity, and fluid can be drawn into the lens, and over time the lens can become opacified and develop into a cataract. Sorbitol is also believed to play a role in the development of diabetic neuropathy. Sorbitol can accumulate in Schwann cells, and recall that these are the myelinating cells of peripheral nerves. When Schwann cells develop osmotic damage, this can lead to neuropathy. Diabetic neuropathy classically causes a stocking and glove sensory loss. The sensory symptoms typically dominate. You can have motor symptoms in diabetic neuropathy, but they are usually much less significant than the sensory symptoms. The longest axons are affected most. Often it's the feet and the legs, and it tends to be worse distally and better proximally. And this can help you differentiate diabetic neuropathy from other causes, for example, a B12 deficiency. In a vitamin B12 deficiency, the lower extremity will be affected equally. In diabetic neuropathy, as you move more proximally up the leg, the sensation will improve. Typically, patients lose vibration sense and proprioception first. Later, there can be impairment of pain, light touch, and temperature. And sometimes the autonomic nervous system can be involved. Patients with diabetes who develop an autonomic neuropathy can develop postural hypotension. This is where their blood pressure falls when they stand up, and they can become dizzy and pass out. In addition, some diabetics develop an autonomic neuropathy involving the GI system. They can develop delayed gastric emptying and can potentially develop gastroparesis. I told you before that diabetics can develop peripheral vascular disease, which leads to poor blood flow to the feet. When that is combined with neuropathy, this creates a big problem known as diabetic foot disease. Because of the neuropathy, diabetics do not feel small cuts and injuries to their feet, and then the poor blood flow does not allow those wounds to heal. So neuropathy plus ischemia can lead to ulcers on the foot, infection of the foot, and potentially this can lead to amputation. And all of this is made worse by the poor wound healing from peripheral vascular disease. Because of the risk of diabetic foot disease, diabetes patients require regular foot exams to detect any injuries early and make sure that they heal. When you do detect an injury or an ulcer to the foot, it has to be managed very carefully. The management of diabetic ulcers is complicated. It involves close wound management, usually by a wound care nurse. Sometimes antibiotics are used, and sometimes diabetics have to go several times a week to a hyperbaric oxygen chamber. This drives oxygen into the ulcer and helps it heal when it otherwise might not. Diabetic retinopathy can cause blindness among diabetics. There are multiple underlying mechanisms that are likely involved. AGEs have been shown to play a role by leading to capillary basement membrane thickening. There is evidence of hyaline arteriosclerosis as well. But from the point of view of sorbitol, what you should be aware of is that the pericytes in the retina degenerate in diabetic retinopathy. Pericytes are cells that wrap capillaries, and there is evidence that sorbitol accumulates inside of the pericytes and leads to osmotic damage. When the pericytes degenerate, microaneurysms in the retina can occur, and they can rupture and lead to hemorrhage. And microaneurysms and hemorrhage are classic features of diabetic retinopathy. And diabetic retinopathy is the basis for annual screening of diabetics. They need to have annual eye exams to detect any diabetic retinopathy early so it can be treated. On this slide, I've listed some of the many findings in diabetic retinopathy. As I said in the last slide, microaneurysms and hemorrhages can occur from loss of pericytes. Exudates can be seen from leakage of proteins and lipids. Cotton wool spots are sometimes seen. These are spots that look like cotton wool. They are nerve infarctions. This results from occlusion of precapillary arterioles. And finally, vessel proliferation sometimes occurs in the retina. This is called proliferative retinopathy. Retinal ischemia leads to new blood vessel growth, and those new blood vessels can damage the retina. This is called neovascularization, and this is one of the reasons diabetics are screened every year. When this is detected early, it can be treated with laser therapy. On this slide, I've listed the complications of diabetes and shown where non-enzymatic glycation and sorbitol accumulation may play a role. I should comment that the development of these complications is highly complex. It is much more complex than is indicated on this slide, but on this slide I've tried to show you that non-enzymatic glycation has been implicated in the development of atherosclerosis, which leads to coronary disease, stroke, and vascular disease. Non-enzymatic glycation has also been implicated in diabetic kidney disease and retinopathy. Sorbitol accumulation has been implicated in retinopathy as well as cataracts and neuropathy. I'll finish this module with this slide comparing type 1 and type 2. So remember that type 1 diabetes is caused by loss of insulin. Type 2 is caused by insulin resistance. The insulin level is always low in type 1. It can be initially high and then low later in type 2. On a biopsy in type 1 diabetes, you see insulitis, which is lymphocytes in the islets. In a biopsy in type 2, you see amyloid deposition. Type 1 diabetes tends to occur in children. Type 2 tends to occur in adults. In fact, type 2 diabetes is sometimes called adult onset diabetes. The genetic predisposition is weaker in type 1 and stronger in type 2. And then finally, type 1 diabetics, because they lack insulin, are at greater risk for DKA. Type 2 diabetics, because they still have some insulin around, tend to develop HHS instead. And that concludes our module on diabetes.